afternoon, students. This is Dr. Trashasset. I'm sorry I missed the lecture the other day with all these changes in the schedule. I don't know. I must have written down the wrong date and time for the lecture. I can't keep up anymore. I mean, I know you guys are all getting changes to your schedule. Also, it's just when you have multiple courses going on, it's sometimes hard to keep up. So today we're going to talk about non-odontogenic tumors. And first I just want to do a little recap about BFOLs. But I have to apologize. I've been waiting today for some reason. They're doing construction above me. And so you might hear some noise in the background. If it gets too loud, I'll stop and I'll start again. But of course, when I'm trying to record a lecture, somebody start doing construction. All right, so let me just get this started. All right, so I know Dr. Bacardi talked to you maybe a week or two ago about benign fibroosseous lesions. But I just want to do a little recap because he really only spoke about the radiographic findings. So the very beginning of this lecture, just review this as far as the benign fibroosseous lesions. Remember that when we sign out a case as a benign fibroosseous lesion, we basically histologically can't tell the difference between the lesions, and that you need some clinical information and usually radiographs in order to make that diagnosis. Again, I'm sorry about the noise. It's a process more than a specific diagnosis, and the diagnosis is dependent on the clinical and histologic and radiographic correlation with the histology. So the basic categories are, when you think of BFOLs, there's basically three types: fibrous dysplasia, ossifying fibroma, and cementoosseous dysplasia. And then within cementoosseous dysplasia, there's three types: florid, focal, and periapical. And within fibrous dysplasia, you basically have one bone affected or more than one bone affected. So it's either monostotic or polyostotic. And then within ossifying fibroma, there is one type that seems to be a little more aggressive. And so sometimes in the literature you might see this one is a juvenile ossifying fibroma. It just seems to have a more aggressive behavior and recurs more frequently than a typical ossifying fibroma. So you had this part before as far as the fibrous dysplasia. Now we now know that there's a mutation of GNAS1 gene associated with fibrous dysplasia, and that there are a number of forms of fibrous dysplasia that are polyostotic. And the two most common ones that you need to know that often come up on board exams, for example, are the JAF-A and the Albright or McCune-Albright syndrome. Monostotic is by far more common. The one thing that I don't know if you talked about before is when it's maxilla is involved, they usually refer to it as craniofacial fibrous dysplasia because you don't know whether it's monostotic or polyostotic, because the extension from the maxilla can be to like the zygoma and other bones in the area, and so because the bones don't have a joint between them, it could just spread from one bone to the next. So they generally refer to that as craniofacial fibrous dysplasia rather than monostotic or polyostotic. For polyostotic, so it has to be two bones or more, and in some cases it can be up to 75% of the skeleton that's involved. A common finding that's associated with polyostotic fibrous dysplasia is a pathologic fracture. That's often the way the children first present if they have fibrous dysplasia, is that there's been, they were playing soccer or they were playing a game and they have a bone fracture, and when they go to have the bone set, the radiograph shows that they have fibrous dysplasia. So you can see the opacity, the maybe radiolucent and opaque finding that we associate with fibrous dysplasia. So another finding seen is hockey leg deformity, and this is where the lower leg has sort of that curve that we associate with the bottom of a hockey stick, and this is a common finding with fibrous dysplasia. So as we mentioned before, there's a Jeff-A type and the McCune-Albright type. The main difference between these two is that both of them are polyostotic and both can have cafe au lait pigmentation of the skin. But with McCune-Albright, you see endocrinopathies to the point that some of these patients will have precocious puberty. They could, females could start their periods at the age of, say, 7 or 8. They can have pituitary adenomas. They can have hyperparathyroidism. Just so you know, a cafe au lait spot, you remember you can also see them with neurofibromatosis, but it's just an area on the skin that's a little bit darker. Cafe au lait is, of course, coffee with milk, so it's at just a little bit pale tan color, and it's a macule, so it's not raised, and it's just an area of hyperpigmentation. The one main difference between the one seen with fibrous dysplasia and the one seen with neurofibromatosis is that fibrous dysplasia, the cafe au lait spots tend to have this irregular, sort of sharply defined border, whereas with neurofibromatosis, they tend to be kind of smooth, like oval or oblong, but not with these little indentations on the outside. So it's just one of the things that we notice with these. So I'm not really going to go into the radiographic because you've had that already. You know that the ground glass look is associated with fibrous dysplasia as well as the peau d'orange, which is the orange peel or orange skin look. The one thing to remember is why you're getting the opacities. What causes the opacity, and that's that superimposition of all the small little bone trabeculae that are within this fibrous tissue in this disease. And I think he also talked about the superior displacement and the narrowing or loss of the PDL space. A couple examples. This is a more lytic lesion. You can see the expansion on the lingual aspect of the mandible, but these areas that are more radiolucent, there are some opacities, but again, a little difficult to tell where the lesion begins and ends, which is classic with fibrous dysplasia. So is it ending here or does it extend to here? That's always the difficulty with fibrous dysplasia, is to know where it begins and ends. And on this slide, we can see the more commonly ground glass appearance that we associate with fibrous dysplasia. But again, it's difficult. It might be, where is the edge? Is it ending here? Is it here? You can definitely see there's expansion of the inferior border. This also shows you areas where it's difficult to find the PDL space. You can still see it here on this molar, but as you go back to the second molar, very difficult to see the PDL space in this area. And in fact, the density is becoming so opaque that it's very difficult to actually see the roots themselves. And this is not uncommon with fibrous dysplasia, where you basically, the opacity of the lesion itself obliterates the outline of the roots. So this is an oral picture showing you expansion both to the palate and toward the buccal aspect in the maxilla. This is a young girl where you can see that there's a little bit of expansion. You can appreciate the fullness of her cheek. And then clinically, it was mostly expansion on the facial aspect, not really much on the palatal. So you can see here, buccal to the molars, there's some expansion into the vestibular area. And then radiographically, this is a nice example of one of the craniofacial ones. So you can see that the density, the opacity is affecting all the way up to the orbit, and it's become so dense you can't even see the inferior aspect of the orbit itself. And so this would be considered a craniofacial fibrous dysplasia. So the histology, which is one of the things I want to talk about, definitely about the BFOLs, is very similar, whether we're talking about fibrous dysplasia, ossified fibroma, or the cementoosseous dysplasias. You have a background stroma that is fibrous, basically fibroblasts, which are plump. They don't tend to be the tapered fibroblasts. And then there'll be trabeculae of this immature woven osteoid material or woven bone. So you'll remember with bone, an osteoid matrix gets laid down, and then that eventually becomes calcified, and that's what becomes normal bone. With fibrous dysplasia, that doesn't happen in the normal way. The matrix actually arises from the fibrous connective tissue. You don't have fibroblastic or osteoblastic rimming, so you see that down here. You don't tend to see those osteoblasts. What you do see is this osteoid matrix arising from the fibrous connective tissue with no osteoblastic rimming. When there's enough of the material and you see these small trabeculae, they tend to be curvy linear shapes rather than one straight linear line of osteoid matrix. It's kind of curvy. And some people have likened this to looking like Chinese characters. I can't read Chinese, so I can't attest to that. But you may see that they talk about in the literature when you read about fibrous dysplasia that they mention that the histologic picture is similar to Chinese characters. So I don't think this looks like Chinese characters at all to me, but being whatever people want to, I guess, visualize. This is classic for what we see with benign fibroosseous lesions. You see the pale areas where it's fairly cellular is the fibrous connective tissue, and then within you see all these little osteoid, some of them kind of triangular shape, some of them more that curvy linear shape, some of them little droplet-like shapes, round areas. And what we're seeing here, even at low power, is that the osteoid is arising directly from the fibrous connective tissue and that there's no osteoblastic rimming. So this is just another example. Fibrous connective tissue here, very, densely cellular, and then these osteoid matrices or trabeculae arising from within that fibrous connective tissue. And on higher power, so the paler areas here are actually the fibrous connective tissue, here, 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 and then this is seams of osteoid that are all kind of linking up together. And you can see in areas like this, it's becoming a little more calcified. And in areas here, it's less calcified. But you'll notice it's the matrix itself is just seeming to come from the fibrous connective tissue. This is a nice example right here. You have the fibrous connective tissue with some vessels, and then the matrix is arising directly from that. So that's the unusual thing that you see with these lesions. And on very high power, again, fibrous connective tissue, and then you see this osteoid matrix, which is arising directly from the fibrous connective tissue with no osteoblastic rimming. So the treatment here, generally with children, if it's not a major aesthetic issue, they'll actually wait until the child's skeleton has finished growing before they go in and recontour. Because you'll see down here, about 20% of these will regrow after reduction if done prior to the child's skeleton developing. And so trying to not have them have multiple surgeries, they basically wait until the child is older. Now, the exception to this rule is if the expansion or the change in the bone contours is so exuberant or so large that it could potentially cause psychological or social problems for the child, then they'll go in and they'll try to do some sort of recontouring at a younger age. But they try to not do that as much as possible. Of course, radiation is contraindicated because when it was done in the 50s and 60s, what we found was that 15 to 20 years later, these children would develop osteosarcomas. So radiation therapy is contraindicated. So for central ossifying fibroma, this is considered a true neoplasm. The mandible is most common. Women, almost 5 times more than men, which is an interesting finding. And large lesions can cause some sort of expansion. They tend to be well circumscribed, and this is different from the other lesions in the benign fibroosseous group. Not only do they tend to be well circumscribed, but often the surgeons know when they go in that it's an ossifying fibroma because they sometimes will actually shell out from the bone. This is not true of fibrous dysplasia, and it's not true of the cemento-osseous dysplasias. So that's one difference with central ossifying fibroma. It's not associated with impacted teeth. Of course, it can cause root diversions just the way fibrous dysplasia can. Some of the larger lesions that we see in the mandible can cause downward bowing of the inferior cortex of the mandible. And so that's one feature we see with ossifying fibroma. So you can see this area in the anterior mandible, and similar area where we see periapical cementoosseous dysplasia, but a well-circumscribed radiolucency in the anterior mandible. My guess is these root canals were probably done because the provider didn't do electropulp testing to determine if this radiolucency was due to an infectious or inflammatory cause rather than an actual lesion. So don't be that dentist. Always pulp test the teeth prior to starting root canal therapy with this type of radiolucencies. Actually, with any radiolucency in the anterior, well, any periapical radiolucency for that matter. Unless it's a crown and you can't do it, you should really do pulp testing prior to initiating root canal therapy in these cases. This is what we more commonly associate with ossifying fibroma, where you have the areas of opacity within this well-circumscribed lesion. They do tend to be kind of round, so you'll notice if you think of this as the center, it's a fairly well-circumscribed round lesion with some areas of less density and some areas of very dense opacity. Another example that is mostly radiolucent, this is showing you the inferior bowing of the inferior cortex of the mandible. Histologically, very similar. The one thing that might be a little bit different with ossifying fibromas versus fibrous dysplasia is you might get a few more of the sort of droplet-like ossifications, the ones that are more like sphericals, which you don't see quite so much in fibrous dysplasia, but again, they're so similar you can't make the diagnosis just on histology. But as I mentioned before, the surgeons often know what it is when they're removing it because it removes much more easily than any of the other benign fibroosseous lesions. So here you can actually see this is muscle up in the top of the picture, and then this is the lesion down here where even at low power you can see these sort of spherical shaped opacities within the fibrous connective tissue background. And on high power you can see very cellular fibrous connective tissue background stroma, and then within it you have all these areas of calcification which develop, some which are nice and round, some which are a little bit more irregular, maybe trying to be more like trabeculae. The juvenile ossifying fibroma, just to remind you, this is a lesion that has a more aggressive biologic behavior, tends to be seen in a younger age group. The orbital and the frontal bones of paranasal sinus are the most common, which is why we talk about it, because it's in the head. It does have a very rapid growth rate, and it tends to cause exophthalmos and proptosis in these patients. The appearance, of course, will depend on what location, which bone is involved, and typically you're going to see a mixed radiolucent radiopaque lesion. They do tend to be fairly well demarcated, but they can invade and erode the surrounding bone, which you'll see in this patient. You can see there's a little bit of fullness on one side, just under his eye, and then if we look, you can see that this is the maxillary sinus, which basically the tumor is in, or part of, it's probably, when you compare it over here, so this is the maxillary sinus on this side, it looks actually more like it's pushing the bone in, sort of constricting the sinus, but you can see the lesion here, fairly well circumscribed, circular margin on the facial aspect, but you can see that it's invading the bone on the more medial aspect. Histologically, again, dense fibrous connective, well vascularized fibrous connective tissue. One thing that's a little more commonly seen with this is that you do tend to see more seams of osteoid and less singular trabeculae, but there's, it's not enough that you can hang your hat on. If you start to see clusters of multinucleated giant cells, it gives you a little bit of a hint, but again, you need to have the radiographic and clinical to make the final diagnosis. So this is the same picture that we've seen before, fibrous connective tissue, fairly cellular fibrous connective tissue with these seams of bubblegum pink osteoid matrix being laid down. So the three cementoosseous dysplasias, periapical, focal, and florid. The periapical type most commonly affects the anterior mandible. Women up to 14 times more often than males, and as you heard previously, predilection to black females. The teeth almost invariably are responsive, so this goes back to what I was talking about before, that you need to do electric pulp testing on these cases. Radiographically, you saw before, it can range anywhere from osteolytic to osteoblastic, so this is an example of periapical cementoosseous dysplasia in the osteolytic phase, where you see these radiolucencies around the apex of the anterior teeth. And this is an example of the more sclerotic, or radiopaque radiographic imaging, where you see it almost looks cloud-like, gets very dense around the roots of the apices and the anterior mandible. The histology is the same as we talked about before. Again, fibrous connective tissue, and you can see why we need the radiographic, because as we go through all of these, they look very similar. You need to see the radiograph in order to be able to make the identification. So focal cementoosseous dysplasia has overlapping features with florid and periapical. One difference is that this is found a little more frequently in white females than the periapical or the florid. But again, women much more than men. And these tend to be seen more in the posterior mandible, but affecting only one quadrant. And that's what helps to differentiate it from florid cementoosseous dysplasia, which of course is going to affect more than one quadrant. It tends to have somewhat irregular borders, but is still fairly well defined. It is sometimes difficult to determine whether or not this is a focal cementoosseous dysplasia or a central ossifying fibroma, just from the radiograph, but once they go in to do the surgery, that's really what can tell you. The other thing that we don't know when a lesion first appears is if the patient is going to develop more. So potentially, focal cementoosseous dysplasia could just be the first lesion in someone who will eventually develop florid cementoosseous dysplasia. So here's an example, radiolucency around these two, well, basically between the premolar and the canine, getting up close to the crest of the ridge and extending past the periapical area. The outline is maybe a little bit jagged and irregular in shape, but is still defined. So it's not smooth, but it is defined. Another example around the apex of this premolar. Again, maybe a little opacity within this lucency. This is another example, and you can see the radiolucency here, and maybe up on the crest of the ridge as well. Again, fairly well defined, not as nice and round as a ossifying fibroma would be, so that helps you with the differential. And in the distal aspect of the molar here, you can see fairly well circumscribed lesion with some opacity or a more radio-dense area within the center. Histology is a benign fibroosseous process, so microscopically it looks very similar to what we've seen before. Sometimes you can actually see continuity with the cortex of the bone, depending on which bone it's in. So this is just happens to be an example where you do see the cortex. So this is muscle up here, this whole area up here. Oh, not this one, but up here is muscle and fibrous connective tissue. And then this is the cortical portion of the bone here. And then you can see down here the lesion, as well as a piece up here of the lesion where there's a fibrous connective tissue with the, this one has a spherical. These are more the curvy linear trabeculae. So florid, as we mentioned, is more than one quadrant. It's not limited to, I'm sorry, it is limited to just the jaw bones, which is one of the things that helps you differentiate this from other lesions in the differential, such as Paget's and Gardner syndrome, for example. So florid cementoosseous dysplasia has those multiple areas of opacity, which you also would see in Paget's. and which you could also see in Gardner syndrome. But florid cementoosseous dysplasia is just limited to the jaws, whereas Paget's disease, multiple bones can be involved, and with Gardner's they would have other symptoms such as polyps in the colon. So that's one of the ways that you can differentiate between those lesions. But all three of those lesions can have opacities that are affecting more than one quadrant of the jaws. The etiology here, we're not sure exactly what the etiology is, but we think that the patients are having some sort of abnormal reaction and thought to be reactive, but we don't know to what. Whether it's a viral infection, whether it's some sort of a vascular reaction in the bone, we don't know what the underlying cause is for florid cementoosseous dysplasia or for cementoosseous dysplasias in general. Interestingly, a simple or traumatic bone cyst can develop within areas of florid cementoosseous dysplasia, so you can have both. And the key thing to remember about the cementoosseous dysplasias, and actually fibrous dysplasia for that matter, is that because the bone becomes so sclerotic, it doesn't have a lot of vasculature, and so it's prone to poor healing and therefore osteomyelitis. And if the patients get osteomyelitis, because of especially with florid cementoosseous dysplasia, because so much of the bone is involved, they can get this sort of slowly smoldering kind of osteomyelitis that is extremely hard to treat. Because how would you treat it? You would give them an antibiotic. But if they have a vascular bone, the antibiotic can't get to the area to take care of the bacteria, and so the patient basically ends up losing the bone. One of the things to remember is because of this poor healing, with any of the lesions of cementoosseous dysplasia, you want to have the patient have impeccable oral hygiene and recall visits so that they don't lose teeth and they don't develop any infections within the bone. Radiographically, I'm sure you talked about this before, the irregular opacities within the bone. So here's a clinical example. You can see florid cementoosseous dysplasia is probably one of the few cementoosseous lesions that can actually cause expansion, and you'll see in the vestibule here, you're getting a little expansion toward the buccal aspect. And then radiographically, you can see multiple quadrants, 4 quadrants involved in this particular patient of this patchy, radiopaque, radiolucent lesion that's affecting both the posterior mandible, the posterior maxilla, as well as some of these areas more anteriorly. So another example, you can see the patchy opacities in the background of the radiolucency here and in the maxilla as well. And another example, again, the mandible is affected in multiple quadrants. It looks like there might be something going on. There's a little burnout up here, so I'm not sure. But it looks like something in the posterior maxilla is happening. But again, you have these areas that could be radiolucent and then radiopacity within. Just a close-up showing you the variability with areas that are more radiolucent and areas that are more radiopaque. Histology is similar to the other CODs. So you have the fibrous connective tissue stroma with the woven bone and spheroid droplet-like areas of osteoid. So you can see the dense, fairly cellular fibrous connective tissue stroma, the curvy linear trabeculae, and then areas that are more spherical. So again, it looks very similar to what I've shown you for the other lesions. You don't tend to see the osteoblastic rimming. The bone seems to arise directly from the fibrous connective tissue. Another example, no osteoblastic rimming. The bone and matrix is arising directly, you can see it here as well, from the fibrous connective tissue stroma. This is an older lesion, so it's been around a little bit more. So here it's very young, kind of woven bone, versus this one where you can see the reversal lines, a little bit older bone. It doesn't look like normal lamellar bone, of course, but you could just tell that it's been around a while longer, and that there's been fusion of a lot of those little osteoid spherical elements together. Again, fibrous connective tissue background. this is something that we would see more with a person who is older. So if a biopsy is taken in somebody who has had a long-standing lesion, this is the kind of bone pattern that you would see in that particular patient. So treatment, as I mentioned, is basically preventive. You try to not have to have these patients have any sort of surgery, and any sort of placement of implants is contraindicated. If they have to have some sort of denture, you want it to be tooth supported rather than soft tissue supported, because as the contours of the bone change, a denture can sometimes ride on a high spot, and once you get an ulceration then in the mucosa, that can lead to bacteria getting into the bone, that can lead to an osteomyelitis, and so you want to try to prevent that at all costs. All right, so if you have any questions about benign fibroosseous lesions, just email me. So we're going to go on and we're going to talk about the non-odontogenic tumors of the jaw. And the majority of the ones we're going to be talking about are actually malignant lesions. And so this is just from one of the radiology texts, just sort of giving you hints of things that we've talked about with a number of different lesions over time, and even in general pathology that I talked to you about, that are sort of common findings of malignant lesions when we look at radiographs. Things, you know, an ill-defined, destructive lytic lesion. If you start to see these spiculated edges of a cortex, or even the onion skinning type laminated images, these are all things that that are sort of associated with malignant lesions. But just read through this so you're familiar with it. The first lesion we're going to talk about is chondrosarcoma, but I put the terms chondroma and chondrosarcoma both on here because there probably is not a true benign cartilaginous lesion of the jaw. What we found is that the ones that were diagnosed as chondromas tended to recur and recur and recur and eventually metastasize. So most likely things that had been previously called chondromas were just low-grade chondrosarcomas because of the fact that they kept coming back and back and back. So you should view any cartilaginous lesion in the jaw with suspicion, because the likelihood is it's going to be malignant or become malignant, or is a low-grade malignancy to begin with. So chondrosarcoma itself is a malignant tumor that forms cartilage. It makes up about 10% of all primary bone tumors. So the primary bone tumor is a tumor of bone that starts in the bone. All right, and average age of presentation is about 33 years old, so a fairly young age group. The patient's chief complaint is usually some sort of swelling that doesn't have to be associated with pain. But often can be associated with tooth mobility. One interesting finding that we see with chondrosarcoma, with osteosarcoma, and actually I've even seen it with some leukemias and lymphomas, is a symmetric widening of the PDL space, which is not a common sign that you see with periodontal disease. Usually the change that you see in the PDL is sort of V-shaped, with an inflammatory process. This is a sort of a widening of the PDL space that is the same from the coronal area all the way down to the root. And often, I'll show you a couple of examples. It's difficult to appreciate it, but when you find patients who end up having a diagnosis of chondrosarcoma and go back and look at their imaging, this is a finding. The symmetric widening is a finding we often see. So if you see this in a patient, you should view it with a high degree of suspicion. The lesions themselves are usually poorly defined radiolucencies, but they can have scattered opaque foci because some of the cartilage can actually become osseous over time. You can have that sort of change just the way you do with cartilage in the long bones. So this is an example of the symmetric widening of the PDL space along here. So you can see it's basically the same width widening of the PDL. The other thing is that the quality of the bone here is not normal. You can see these areas of radiolucency, and even here, some radiolucency coming from the PDL space here. So all in all, this area was a little bit suspicious in general, but the widening, the symmetric widening of the PDL space is also extremely suspicious. So this is a case of a woman that I saw when I was a resident. And she had initially presented prior to me being a resident with this image, where you can see there's an ill-defined radiolucency in the maxilla. Her chief complaint was that she had movement of her front teeth. The issue here for this patient, she was living on the street. She was homeless, and she probably had some psychological issues. So she was told what the diagnosis was, and that it was recommended that she have a hemimaxillectomy. But that's not what she wanted. She just wanted dentures because she wanted her teeth to look okay. She didn't like the way these teeth were arranged. So she went away and was lost to follow-up and returned back to the clinic a number of years later. This was when I was first in residency. And she presented with someone who had done her extractions and made her a denture. But now her chief complaint was that her denture didn't fit, and she wanted somebody to fix her denture. Now, when we did the oral exam, you'll notice that there's a nodule here in the front of the maxillary process, and if you look in the palatal, you can see it's a raised, fairly large, probably I think it was like 2 to 3 centimeters in size. And it's no wonder her denture's not fitting, because she still has her chondrosarcoma. So we advised her that, again, the treatment should have been excision of the anterior aspect of her maxilla with repair of the denture, but she did not want that therapy. And so she was lost to follow-up again. This is the radiograph of when she came in, and you can see still has the ill-defined radiolucency in the maxilla. And when she came back in my last year of residency, so this was 3 years later, you can see now that lesion has become quite nodular. It's extended into the areas back here, so she's lost alveolar height in this area, and she had metastasis at the time. And so again, she was advised the best treatment would be to have chemotherapy and have this lesion removed. But she was actually admitted to the hospital for this, but then had second thoughts and left against medical advice and was lost to follow-up, and was presumed to have probably passed away not too long after this because she had mets to the lung. This is another example of somebody who had a chondrosarcoma of the mandible that has extended, you can see, up into the tongue. These can be fairly rapidly growing lesions. The patient that I showed you before, hers actually, so I think from the first image to this image was about 4.5 years. So hers did not grow as rapidly as it could have. But this one was slightly different and was a fairly rapidly growing lesion. So the histology for chondrosarcoma, basically what you need to see is cartilage showing varying degrees of maturation and cellularity. You often see the cells within the lacunae have a lot of pleomorphism, and you often see 2 cells per lacunae, which is not normal. Normal chondrocytes are fairly small, round cells, and there's typically only 1 per lacunae. The tumor itself tends to grow in a lobular pattern, and as I mentioned, the neoplastic cartilage can actually have endochondral ossification, so sometimes you do get a little bit of opacity within the lesion. So this is epithelium, so this was the mucosa up here. This is fibrous connective tissue, and then this is the lesion, and you can see that the ground substance of the tumor itself is very pale. It's rather sort of a basophilic, pale basophilic stroma, and then you can see areas where it's very cellular, where the nuclei are very hyperchromatic, and this is showing you the sort of lobulated, where you have one lobule here, another one here, and another one here, that's so common with chondrosarcomas. This is on high power, so this is showing you a bone trabeculae, and then this, again, sort of pale basophilic stroma of the chondrosarcoma. If you look at the nuclei themselves, the nuclei are showing a lot of pleomorphism, some which are quite large, like here and here and here, some which are fairly small, but there's 2 per lacunae. You can see 2 in this lacunae. Down here, pretty much every lacunae has 2 cells within it. So this is this basically what we see with chondrosarcoma. Treatment for chondrosarcoma tends to be sort of a pretty big surgery. You want to be able to remove the entire lesion because chondrosarcomas do not respond well to either radiation or chemotherapy. It has a prognosis that's worse than for osteosarcoma, which is different than the prognosis for areas outside of the jaws. And then treatment failure for chondrosarcomas is typically that you didn't get it all. And so it's uncontrolled local disease, not necessarily metastasis. So this is an interesting case of an 83-year-old female who presents with a bump under her denture on the alveolar ridge. And so her denture's rocking, so that was her chief complaint. And as you see here, this is from Dr. Fowler, who was a colleague at the time at University of Kentucky. And so if you look at the edentulous ridge, there's this bump in this area. And so this was what was causing her denture to rock. So this was biopsied, and on biopsy you can see there's areas here which look cartilaginous and areas here which was cartilage that's now becoming bone. So the question that you might ask, is this a chondrosarcoma? So I want to emphasize that no, it's not, because this was in the soft tissue of the mandible, not in the central medullary part of the bone. So even though it has areas that you can see the chondrocytes and you can actually see some bone forming within the cartilaginous tissue, this is a reactive lesion that's referred to as a cut-right lesion. It is not malignant. It is a benign lesion that's reactive, usually due to a poor fitting denture. And what happens, you can have either cartilage or bone within the gingiva. It's not central in the bone. So our next lesion is osteosarcoma, and this is a malignant tumor of bone formation. When we talk about malignancies within the jaw, the most common malignant bone tumor is actually a metastasis from somewhere else in the body. So breast cancer metastasizing to the mandible, for example, or prostate cancer metastasizing to the maxilla. That is the most common malignant tumor of the jaw bones. If we talk about primary bone lesions, or a lesion that starts within that particular bone, and we're looking at the jaws, then multiple myeloma is the most common primary bone malignancy, and osteosarcoma is the second most common primary malignancy. The difference is, if we want to then parse that down into age, if we look under 40, osteosarcoma is more common, because most people who get multiple myeloma are over 40. So for patients who are under 40 who have malignancies in the bone, the most common primary bone tumor is osteosarcoma. The mean age of presentation for the jaws is 33, so very similar to what we were talking about with chondrosarcoma. And this age is about 15 years older than that for the long bones. So patients who are usually diagnosed with osteosarcoma of the long bones tend to be either teenage, sort of late teenage into early 20s. So a little bit different than the jaw lesions. The interesting thing about osteosarcoma is that the patients will often complain of pain and swelling, and a quarter of the patients actually will say they have a toothache. And that's kind of an unusual finding with malignancies. The patients don't often complain of toothache. You can also see the loosening of the teeth. Any malignancy that's growing in bone can cause loosening of the teeth. Again, paresthesia of the lip is one of those findings that we associate with malignancy. Anytime a patient has a mass within the jaw and has paresthesia, we're always worried that that's going to be a malignant lesion. If it's up in the maxilla, of course, you could have nasal obstruction. Again, as I mentioned previously, you can see that symmetric widening of the PDL space. With osteosarcoma, you would think because it's a bone-forming tumor that it would always be radiopaque. But interesting, because there's a number of different forms of osteosarcoma, it could be anywhere from a radiolucent lesion to a mixed radiolucent radiopaque to a radiopaque lesion. So it varies quite a bit. It will have the typical malignant pattern of an ill-defined lesion with an indistinct margin. You can see spiking root resorption, which is not definitive for a malignant lesion, but is definitely associated with malignant lesions. About a quarter of osteosarcomas will have the sort of the classic sunburst or spiculated pattern on the periosteum. This is seen more readily with either an occlusal film or a CBCT. So this gentleman was in his late 20s, came in, and you can appreciate swelling of the side of the face here. And he actually mentioned that he was having problems opening. He was restricting, his opening was restricted, which you can see here. There's not a lot of space between the two teeth. But when you look back at the posterior, you might think that this is just an inflammation of the operculum. Maybe he has a little infection around his third molar that's partially erupted. But on imaging, so this is a anterior posterior image, plain film, you can see that basically most of his mandible is gone. There's a radiolucency that's taken the ramus and the coronoid notch, and it looks like even part of the mandible itself, and it looks like it's going up into the condyle as well. This is a different patient, and you can see in the maxilla, there's an exophytic lesion that's expanding the buccal aspect. This is sort of that spiculated sunburst appearance that they talk about on the cortex of the bone, but it's definitely opaque, so it's definitely making bone. And this is another example. This one looks a little more smoky. When you look at the expansion on the buccal and the lingual, there's areas that are maybe a little bit less radiodense and areas that are more radiodense. This was a young girl who came in, and again, it's very easy to appreciate the swelling she has on her cheek here. Radiographically, you can see she had a radiolucent lesion. So this one actually looks, on this particular image, fairly well defined, but if I go back, you can see this is a fairly large lesion. It actually extended up the ramus, and so in that area, you can start to see that there was some opacity showing. It was mostly radiolucent, but there were definitely some opacities within it. So the histology, by definition, an osteosarcoma has to show some sort of osteoid matrix, the matrix of bone, being laid down by malignant stroma or sarcomatous stroma. So osteosarcomas, there's a number of different types. They can produce bone, they can produce cartilage, or they can produce just fibrous connective tissue. So 3 of the types of osteosarcoma, there's actually more than these 3, but 3 of the types of osteosarcoma could be osteoblastic osteosarcoma, chondroblastic, or fibroblastic. And depending on which of these 3 types you would have, it would determine whether you have something that's more radiopaque or more radiolucent. So for example, a fibroblastic type of osteosarcoma is going to be more radiolucent because the fibroblastic component isn't making as much bone. Whereas if you have an osteoblastic osteosarcoma, that's more likely to show opacity and a lot of density within the lesion. And of course, chondroblastic would be kind of in between. All right, so we can see here the stroma is very cellular, a lot of pleomorphism within the cells. Some of them are spindled, some of them are round, some of them are polygonal. And then within this, you see osteoid matrix being laid down, which you see in a number of different areas. On higher power, this is another lesion, not the same exact lesion, but you can see this is the osteoid matrix up here. Within it, these very hyperchromatic, very pleomorphic looking cells. And then if we go back down to the stroma, these are the malignant stromal cells that are making the osteoid. So again, the look that we associate with malignant cells, hyperchromatic, a lot of variability, a lot of pleomorphism. And on high power, eventually you'll see mitotic figure. There's actually another one down here. and this is an abnormal mitotic figure where you have the rings. But again, the sort of bubblegummy pink osteoid material being laid down, which is starting to calcify in this more magenta tone. Treatment for osteosarcoma is currently preoperative multi-agent chemotherapy to shrink the tumor and then followed by surgery. Radiation alone will not cure osteosarcoma. The best chance, just like with chondrosarcoma, the best chance is to be able to cut it out. And so the more favorable site is a mandibular symphysis. And the worst site to have osteosarcoma in the jaws is the maxillary sinus because of the location that's so close to the base of the brain and other vital structures. The 5-year survival rate for osteosarcoma has historically been around 20%. With some of the newer chemotherapies that are more targeted to the particular type of osteosarcoma, that could be up a little bit, and it can go up as high as 80% if the lesion is caught early and it's in an area that could be removed. So, for example, if it's the long bone and it's in the tibia and you can amputate the lower leg, the patient is going to have a much greater success and a much more likely to live their full life rather than if you can't do a good surgical excision. There are also peripheral osteosarcomas, also referred to as juxtacortical, and these, the peripheral in this instance is not like a peripheral ossifying fibroma, which is within the gingiva. With peripheral osteosarcomas, they're talking about peripheral being the cortex, that these are tumors that arise on the surface of the bone versus centrally within the bone in the medullary space. There's 2 types of peripheral osteosarcomas. There's parosteal and periosteal. And this just sort of highlights the difference between the two. The parosteal is a mushroom-like growth on the surface of the bone. It does not elevate the periosteum, whereas the periosteal type, this is a sessile growth that elevates the periosteum and then bone fills underneath that periosteum. The prognosis for the periosteal, actually the prognosis for juxtacortical are better than a conventional or medullary osteosarcoma. The periosteal is better than the medullary, but is worse than the parosteal. So the best type to get is the parosteal, not the periosteal type of peripheral osteosarcoma. Our next lesion is Langerhans cell histiocytosis, and talked a little bit about this in general path, but we're going to go into the more specific features here today. Males are affected much more often than females. Age group is usually less than 10 at initial diagnosis, and the jaws are affected anywhere from 10 to 20% of the cases. Common sites of involvement are the skull, the rib, the vertebrae, and the mandible as well. The lesions associated with Langerhans cell histiocytosis often have pain or tenderness, and it can mimic severe periodontitis. And this, because most of the cases are in children, it would be the severe periodontitis that you see in children, which used to be called juvenile periodontitis, but now with the new classification, it could be called a number of different things based on my talking with the perio department, so I'm just going to call it severe periodontitis, because it could fall into a couple of the different categories that they have nowadays. So there's basically 3 different types of Langerhans cell histiocytosis. You have the acute disseminated, which previously was called letter or seaweed disease. You can have the chronic disseminated, which previously was called Hanschel-Christian disease. And then you can have the solitary type, which is eosinophilic granuloma. This is much less common and is usually seen in adults. I'm not really going to talk about this disease. I'm going to sort of spend our time on the acute disseminated and the chronic disseminated. The acute disseminated is usually multisystem, is seen in infants, and usually has a fairly high mortality rate. The children hardly make it to a year of age. Very bad disease. The chronic disseminated form, the children are usually initially diagnosed a little bit older. It tends to be more of a unisystem disease. Frequently it's the bone, but it could also include the skin or the viscera. It again has a fairly high mortality rate. I had a patient who had this a few years ago. The surgeon thought that they had dentigerous cyst, and it ended up being Langerhans cell histiocytosis in a 17-year-old. But with chemotherapy, they're doing a better job at being able to manage these patients. So some of them can live into adulthood, but they usually do not have a normal lifespan. So as I mentioned before, the site depends on the clinical form, but all of these are neoplastic proliferations of the Langerhans, and this was just put in to remind you of what the Langerhans cells do. This is a child who had the acute form of disseminated Langerhans cell, and you can see multiple lesions affecting the skin and also the mucosa. So you can see a young child just has the two front teeth so far, and so the maxilla is edentulous, basically, because the teeth haven't erupted yet. But you'll see this area of ulceration and erythema in the posterior part of the palate, which was associated with Langerhans cell. This is an older patient. You can see that the infiltrate within the gingiva is causing a lot of erythema, and these teeth were very mobile because most of the bone had been lost in these areas where the gingiva was erythematous. So most of the what we're going to talk about is the chronic disseminated form, and this is the classic triad seen with chronic disseminated is very radiolucent lesions. The patients often have exophthalmos, and they can have diabetes insipidus. Because of the lytic bone lesions, you usually see mobility of the teeth, and this, we talked about this in a number of cases before, this falls into that differential diagnosis of the radiographic picture of bone loss, alveolar bone loss in children, which leads to teeth floating in air. So you'll remember cyclic neutropenia was in this, papillon Lefebvre is in this, Burkitt's lymphoma is in this differential diagnosis. So I know I've given it to you a number of times, so just remember that Langerhans histiocytosis, the chronic disseminated form, also in that differential diagnosis. The lesions don't tend to be corticated. They tend to be punched out radiolucent lesions. Sometimes they can be ill-defined. This is a lesion in the mucosa of the oral cavity, and you can see very erythematous. Often they become ulcerated, and are usually associated with mobility of the teeth in the area. This is a skull film, and you can see these punched out radiolucencies within the skull of this child who had Langerhans cell histiocytosis. This is the alveolar bone loss that we were talking about. So this is an erupting tooth, but you can see the bone around that erupting tooth has basically been destroyed. So it's a lytic lesion. Another example in the mandible showing you the extreme loss of alveolar bone around this deciduous molar. And then this was a case in an adult of an eosinophilic granuloma, so this would be an isolated lesion, but a very similar appearance of loss of bone at the alveolar crest. Histologically, you see the mononuclear cells, which are the Langerhans cells, which have a cleaved or kidney bean shape, and I'll show you what that means in a second. But also they have a lot of eosinophils, which is unusual. There's not a lot of lesions that we see abundant amount of eosinophils in, and so that's an unusual finding. If you do electron microscopy, you actually see Burback granules within Langerhans cells, and I'll show you what those look like. So this is a common finding. You just see sheets and sheets of cells, many of which are the Langerhans cells. So you can see here where there's a cleavage. So some people refer to that as looking like a coffee bean. You can see another one down here where the cleavage is going across this way. See another one here. Again, the cleavage is going across this way. So it's basically a line that's going across the nucleus of a mononuclear cell. Then you have multiple cells. The eosinophils, you'll remember, are granulocytes that have red granules in the cytoplasm. And so that's what you're seeing. Oop, where's my arrow gone? That's what you're seeing up here, is the cytoplasm has those little red granules within the cells. A higher power a different case on high power. And again, you can see the eosinophils that are percolating through this stroma pretty much everywhere. It's a little bit harder to see here's one, you can see a cleavage here. You can see one there on the mono, another one there. It's just that this particular case you can't see as many of those sort of kidney bean or cleave cells. This is an electron microscopic picture of a Langerhans cell and is showing the Burbeck granules. And you can see they look like tram lines sometimes. So both of these are Burbeck granules, but then sometimes they have this little round end. And this is what they refer to as looking like a tennis racket, where you have the elongated part, but then at the end it has this sort of round part, and they refer to this as a racket shape. So Burbeck granules are seen in the Langerhans cells. This is that differential that I mentioned earlier about the alveolar bone loss in children. You should know that differential. So our next topic is Ewing sarcoma. This is one of the family of sarcomas that are associated with Ewing's. There's others like peanut, there's a couple other picomas. So there's a couple other tumors that are within this that you don't have to know. We're just going to talk about Ewing sarcoma. There's a very malignant, very bad tumor, undifferentiated, often referred to as this group of lesions, a small round blue cell tumors, because the cells themselves are small, round, and as you'll see, the nuclei are very blue. The cell of origin is disputed in this. They think it's coming from neural crest, as many of the other small round blue cell tumors are, but we don't know for sure. An interesting feature with this particular tumor, so it's a malignancy that is acting like an infection, like a benign lesion. So patients often present with pain and swelling, but with fever and an elevated erythrocyte sedimentation rate. And you remember fever, of course, you would make you think that the patient has osteomyelitis or some sort of infection. And elevated ESR is sort of a non-specific test that usually is associated with increased white blood cells and therefore with infection. So these lesions sometimes are mixed diagnosed as an infection or osteomyelitis rather than as malignancies, at least initially. The majority of the cases are seen in the femur and the pelvic bone. It makes up about 6% of the malignant bone tumors. In the jaw, the ratio of a primary lesion to a metastatic lesion is 14:1. So much more common for it to be primary in the jaws than to be a metastasis from, say, one of the long bones. This is an example. It was from the arm, and you can see the fairly, I don't think anybody would miss the tumor seen here. It's primarily a disease of children and adolescents, so most of the cases are between 5 and 30 years of age. Much more common in males, so 60% in males, and only a small percentage affects the jaw bones, and when that happens, it's more common to be in the mandible. It's a disease that's seen more commonly in Caucasians than either blacks or Asians, and the lesions will often perforate the cortex and grow into the soft tissue surrounding the bone, which is a problem because the reconstruction aspect of the surgery becomes more difficult. So this is an example in the orbit. So in the skull, you can see the fairly large lesion causing exostosis or exophthalmos of the eye, but very destructive lesion here coming into the brain in this area, into the cranial vault. So clinically, as malignancies, we've talked about many times, paresthesia is associated with these lesions. You can have loosening of the teeth. You often see this irregular lytic lesion with ill-defined margins. You can see root resorption, often spiky root resorption. An interesting feature with Ewing's is that you might see onion skinning, or that sort of laminated layers on the periosteum, similar to what you would see with peripheral periostitis, which is a benign lesion. It's seen more commonly in the long bones in the jaw, but it can be seen. I've seen 1 or 2 cases in the jaws that actually show this onion skinning or laminated appearance. As I mentioned, the histology, you really can't make this diagnosis just on regular H&E histology alone. You need to use immunohistochemicals tests. But the histology is small round blue cells in just sheets and sheets. They just line up right next to each other and don't really see any sort of background stroma. You often see very large areas of necrosis because this is a very fast-moving, fast-growing tumor. So because it's growing so rapidly, it often outgrows its blood supply, and so you get necrosis and hemorrhage. 75% of the cells will actually contain glycogen, and this test is done sometimes in addition to the immunohistochemistry tests. So as you can see here, it's very uniform. You have just these sheets of small round blue cells, and this is what pretty much all the small round blue cell tumors look like. Sometimes there's a little bit of variation within them, but usually we have to diagnose these using immunohistochemical tests. And this is just showing you PAS, which is a periodic acid shift stain, which is highlighting the glycogen within the cell. So this very magenta pink areas are glycogen within the cytoplasm of the cells themselves. Treatment, similar to what we talked about with osteosarcoma, is combined therapy, multi-agent chemotherapy, but in addition they usually do surgery and radiation because this is a fairly bad tumor, which has a very high recurrence rate. And so it used to be uniformly a death sentence, and now with the combined therapy, it's led to about a 40 to 80% survival rate. Again, a lot of that depends on the surgery and if you can remove the entire lesion. Gnathic Ewing sarcomas have a lower mortality rate than the other primary sites, often because it's the mandible that's involved, and you can just, of course, cut it off because it's the mandible. So the last thing I wanted to talk about is metastatic carcinoma. You remember I said the most common malignant tumor to the jaws is a metastatic lesion. And when we talk about what lesions would do that, there's actually a little way to remember it. It's BLT and cold kosher pickles. And so the B is breast cancer, the L is lung cancer, the T is thyroid cancer, the C is colon cancer, the K is kidney cancer, and the P is prostate cancer. And so these are the most likely tumors that will metastasize to the jaw bones. Now, I'm used to this sort of way of remembering it, but really, if you're kosher, you wouldn't be having a BLT, so it doesn't really work together, right? But it is one way to remember metastatic, the most common tumors to metastasize to the jawbone. And so these last few pictures, I received the images from Dr. Chan, who was previously here as a radiologist. And so it's showing you those classic features that we've talked about all along. The ill-defined, sort of moth-eaten radiolucencies where it looks like little areas are taken out around the edges of the lesion. And here you can see the loss of the cortex on the inferior aspect of the mandible. Here you can see on both the right and the left, the rami have basically been destroyed by the tumor, so that there's very little bone left. It looks like there might even be a pathologic fracture there. Sometimes some of these metastatic lesions will actually produce opacity, and sometimes it's a reaction to the surrounding bone, and sometimes it's because they actually are desmoplastic and have a lot of collagen within them, and the collagen becomes so dense it actually forms opacities. This is showing you B here, the spiculated growth, that sort of sunburst pattern on the facial or the lingual aspect, basically the cortical aspect of the bone. And here again, that sort of moth-eaten, irregular radiolucency. Here's that widening of the PDL space here. Any of these should increase your suspicion. Any of these appearances should increase your suspicion for a malignancy in the bone. And last, this is just a nice reminder. It's all things that we've talked about, but just sort of reminder, some pearls when you're studying to help you remember about malignant tumors of the jaw. All right, so that's the end of the lecture, and if you have any questions, please just email me, and I sent an email out, but I'll say it again. For my questions, almost all of them are going to be clinically based. A few of them are going to be case-based questions. The things to remember are, what's the etiology of the lesion or the tumor? How does it present? What are the clinical findings? Does it come with pain? Does it come with a radiolucency? Does it come with a multilocular radiolucency? Does it come with, a change in color? All those types of things. And then treatment. How do you treat them? Is it treated with surgery? Is it treated with medication? Those types of things. And then you need to develop a differential diagnosis. So what are the things that look similar, that present in a similar fashion? And once you have that list, how do you differentiate? What is the thing about each of those lesions in the differential that's different? So what is the one or two things about each of the lesions within the differential that would give you the hint and tell you which actual definitive diagnosis it is? Okay? So good luck with studying, and just email me if you have any questions. Thank you.